Good morning. I'd like to thank the organizers and Dr. Prabhakar Tripanini and Dr. Reddy for inviting me here to give this talk here today. I don't think, or there are not many topics in gynecologic cancer that are more controversial than whether or not we should be delivering adjuvant therapy to an early stage uterine cancer. So historically, how do I advance this? So historically, up until the early 1990s, adjuvant pelvic radiation was delivered or recommended for deeply invasive or high-grade disease, and vaginal brachytherapy was routinely delivered for disease with less than 50% myometrial invasion or for grade 1 or 2 disease. And the biggest controversy was when to deliver vaginal brachytherapy with pelvic radiation. Now, we've significantly evolved since then, and the controversies in 2015 include whether or not we should be delivering any adjuvant therapy to these patients, and if so, should it be chemotherapy, vaginal brachytherapy, pelvic radiation, or a combination of these therapies. Now, the rationale for adjuvant radiation came from multiple observational studies that showed that in low or intermediate risk patients, the cause-specific survival was quite high, as you can see here in the two upper curves, whereas in patients with higher risk in uterine cancer, the risk of recurrence was much higher, even if radiation therapy was delivered. So the use of radiation in the adjuvant setting in early stage uterine cancer, as I mentioned, is quite controversial. In the United States, at least, some centers offer pelvic or vaginal cuff brachytherapy quite routinely, while others rarely refer patients with stage 1 or 2 disease for postoperative therapy. And in general, historically, the rationale for postoperative treatment has been if patients have a combination of high-risk features, including deep depth of myometrial invasion, cervical invasion, high-grade disease, lymphovascular invasion, older age, or perhaps even low uterine segment involvement. Now, there are many considerations that we must think about when delivering adjuvant therapy or recommending adjuvant radiation. In general, most patients with uterine cancer are at a low risk of recurrence. Because these patients typically are obese, they may have other metabolic diseases, including diabetes, they oftentimes die of intercurrent disease. And we must keep in mind that any treatment, whether it be radiation, external beam radiation, or brachytherapy, or even chemotherapy, does impact patients' quality of life. One rationale that many oncologists do use for not delivering adjuvant therapy in the setting is that vaginal recurrences may be salvaged at a high rate with radiation. And finally, we know that radiation has not been shown to improve overall survival in this population, particularly since, as I mentioned, many of these patients die of intercurrent disease. So in designing randomized studies, the better endpoint may be cause-specific survival instead of overall survival. So there are a number of two large randomized studies that looked at defining the optimal adjuvant therapy in intermediate risk uterine cancer, and those were GOG-99 and PORTEC-1, and they were conducted at around the same time period. These studies randomized patients to pelvic radiation or no further adjuvant therapy and included very similar groups of patients, although PORTEC-1 did exclude patients with deep myometrial invasion and high-grade disease. It did not do a systematic lymphadenectomy. But the results were very similar. There was no difference in overall survival in either of the two studies, but there was a significant decreased rate of local regional recurrence in patients that received pelvic radiation from about 9 to 14% down to less than 5% with radiation. Now, one very important observation from these two studies was that the site of local regional recurrence was most often in the upper vagina, with approximately 2/3 of recurrences in both studies occurring at the upper vagina, with very low rates of local regional recurrence in the pelvis region with no adjuvant therapy. Now, not surprisingly, radiation therapy did have a significantly higher rate of actuarial grade 1 to 4 toxicities, 26% versus 4%, But if we look at specifically the high-grade toxicities, grade 3 and 4, these rates were quite low with adjuvant radiation, and almost half of the complications resolved over time. Radiation technique does matter. Most of these patients were treated with an NAPPA or 3-field technique, and they had higher rates of complications compared to those patients that were treated with a 4-field technique.